Welcome to this webinar recording of the results of Digital Collaboration Solutions 2016 Care Coordination Survey. Presenting is DCS partner Tim Perkins.
Okay, so what are we going to do? We're going to do our, going to talk about some highlights. We're going to take a close look at the results, a little bit about implications and next steps. One of the things we looked at the results, we tried to look at to see are there any best practices emerging. Jump-starting results in 2016. What are some things you can do, kind of a checklist or some tune-up items, so you can look at your care coordination activities and see if we can improve them. And then questions and answers. So a little bit about us, just so you have a context of what we do and who we are. We work with a lot of different healthcare executive teams, cross-functional teams, service line directors, and a variety of different types of healthcare organizations. And we provide a lot of different services, but in particular in our care coordination services area, we'll work on things like 30-day readmissions, improving outcomes, transitions of care, referrals, some population health data practices. We do a lot of strategy. We do a lot of working with on quality and HCAP scores, things like that. So we work on a variety of different care coordination activities, and that's the context. So when in this work, we were, we noticed a wide variation of the approaches to care coordination. A lot of, depending, it wasn't just whether you were a SNF, whether you're acute care. We just noticed a lot of people doing it a lot of different ways. So we decided that we looked for some information on it. We really couldn't find it, so we decided to do one ourselves. So we just decided to go out and ask people, what are you doing? What are you doing for care coordination? What's your approach? How are you organized? What are your 2016 priorities? How do you make decisions, etc.? So we put together this survey. We designed it around 15 questions. We didn't want it to be onerous, 5 to 7 minutes to complete. It's not extensive by any means or stretch of the imagination, but it gives us a good indication and a good feel for what people are doing out there. And this was done late 15, early 16. We did the data collection, then we did some analysis and some follow-up, and then we were able to write the survey, and we're real happy the survey is out today. So as a little bit of a framework for everybody, people today are looking at care coordination. How are they measuring it, quantifying it? It's basically these three areas. This is nothing new to people who do care coordination for a living, but it's the quality, it's better care coordination, means better improved outcomes, healthier populations, patient satisfaction. Healthcare is more than ever and becoming more and more a consumer market. So satisfied patients and families tell others about their experience, and unsatisfied patients and families tell others about their experience too. And government penalties and bonuses more than ever are tied to patient satisfaction measures. A hospital compare, star ratings, even though those are getting delayed a little bit, it's all coming around. Patient satisfaction is a huge component of this three-legged stool. And then, of course, financials. Better quality, better outcomes, better patient satisfaction, better bottom line. So these are the frameworks and the context that when people are looking at care coordination, what's the end game. So here's the highlights as we see them, and I'm interested afterwards and during the questions what you might see as the highlights, because I very well could have missed a couple of things here and there. But here's what we see. 70% told us that report patient outcomes is the most important goal. So, and 20% said, no, it's patient experience. Okay, that's good. But that's good news because everybody understands the best way through to make care coordination is all about making the outcomes better or making the patient experience better. And everybody's pretty much on the same page there. 86% said that care coordination improvement efforts are a top 5 priority. So saying, yes, this is important. However, 55% don't have a dedicated budget to make it happen. So that tells us something. Over 3/4 treat this as a process improvement effort. The way that we're going to improve care coordination, the way we're going to look at it, the way we're going to understand it, the way that we're going to impact it, the way we're going to move it forward. It's a process improvement effort. That's how they frame it. That's how they work at it. And 40%, although 75%, 77% say they treat care coordination as process improvement, 40% don't have any defined process on how they're going to do that, to review, approve, prioritize care coordination improvement projects. So they're just kind of shooting from the hip, or they've got a series of processes that they use, but it's really not defined. It's a lot of ad hoc going on out there. And 2/3 of the organizations look at care coordination improvements in an ad hoc and opportunistic manner. So they're reacting. This number went up. Oh, let's form a group to go after it. So there's no real focused long-term effort to go after these measures in a coordinated manner. So we were pretty interested in that. That opened our eyes a little bit. All right, so let's take a look at some graphs. First thing, a little bit about housekeeping. You say, what kind of organization are you? And I'm really happy with the way this came out. We have a really good mix. We've got independent acute care hospitals, or not independent necessarily, but individual hospitals that the respondent was speaking for. We've got a good number of SNFs, some IDNs in there, ambulatory. Ambulatory and home health represent 1/3 of the respondents. So we're trying to go up a little bit and look across the continuum of healthcare, continuum of care. So I'm really happy with the representation here, that between ambulatory, acute, post-acute, home health, etc. I wish our health clinics had been a little bit better, and even some behavioral health. As we all know, it's all getting in the mix, but very happy with that. So we have a pretty wide mix. So we can't say that, oh, this is all about acute care hospitals. Oh, this is all about the individual practice. It's a blended mix. And we also said, what's your title? Right? You're going to put in your opinions. We'd like to kind of get an idea of where you're coming from. And overwhelmingly, oh, I'm sorry, one other thing on this on the previous slide. Other 21%. You kind of look at that and you go, oh, that's material. Most of those were critical access hospitals. So there's also a fair amount of critical access hospitals in the survey as well, which I think is really important to level the mix. So we asked you about the title, and number one, 67% said any of the titles you gave me down there to choose from don't work for me. So we have I'll show you on the next slide the sampling of the titles that we got. But the most congruous the set of titles: chief nursing officers, director case management, medical officers, some chief executives, some C-levels, good representation, not overwhelming, not underwhelming. Service line directors, hopefully we'd have some more there, but we see that they're an important part of the mix. And so overwhelmingly clinical folks got into this response. Okay, so here's a list of the other, pretty extensive. Okay, everybody from administrators to financial people, lots of quality people in there, director of quality improvement coordinator. I guess in an ideal world, you want everybody to be quality improvement coordinators or program managers, but that's not the ideal world. You need the clinical, overwhelmingly clinical, which was good. But there's a good representation, a good mix here too. So we got a good mix of titles across a good mix of types of facilities. So let me just say, very simple question. Coordinated care improvement efforts a top 5 priority. Figuring if they weren't a top 5 priority, you're not going to spend much time on them. It's going to be nice to have. And if they are, great, let us know. Overwhelmingly, 86%. Yes, the top 5 priority. So that seems to reinforce the importance of improving care coordination across the entities and the patient's relevant care network. And a little over 4% said no, not too many other things to do. We'll worry about that later. And then for me, one of the most interesting responses is about 10%. I have no real way of knowing. So I don't want to read into that, but it could be that it either indicates a shortage of goal setting for the organization or effective communication across the staff. But 10% were honest and say, I don't know if it's important or not. That in itself could be the subject of a organizational study. But the key takeaway here, 86%, yes, important to our goals. So this is probably one of the most interesting slides. This is what are you working on? And we allowed respondents to put in as many as they wanted, multiple responses. The average was 5 per organization. So the average organization is working on 5 care improvement projects. And from largest to smallest, so the top 4, transitions, right, between care and between the patients and the families, transitions between facilities, 30-day readmission still ranks up there, and improving patient experience measures. which makes sense because 20% believe that it is the most important. And everybody acknowledges it's one of those three legs of the stool is the patient experience measure. So those are the top four, and then we get into acute care across with home health. That was gratifying to see that people are beginning to the acute home health, ambulatory, across the continuum, being able to reach out to the adjacent sections and coordinate care. Then we put in some financial ones just to see what people would say. Implementing population health is interesting at 25%, but we also put in getting more out of my existing population health investment, because the adoption cycle seems to be we'll go out and spend the money and then we'll get it working, and then we'll figure out how to get it working correctly. It's not trial and error, but it's experience on getting it out there, using it, and then using it and optimizing it. So we thought we'd throw that element in. 2.8% said we'd have no care coordination initiatives. That kind of corresponds with the folks from the other chart that said they're not working on it at all. So this goes across the board. It's interesting that telehealth initiatives, 31%. So people are starting to really understand that, look at it, and again, you can talk to 5 different organizations and get 5 different definitions of telehealth initiatives. Everything from care coordination, nurses, follow-up nurses, because they use a phone. Some people believe that's telehealth, to the full-blown discussion and diagnosing using phone and web. But we just wanted to kind of put it in context and say, is telehealth something you're looking at for care coordination? And 31% of the respondents said, yeah, we've got something going on that. I think that's interesting. And then network leakage. Some people are into that, some people aren't. So you've got it right here. Here's what people are working on. They're working on an average of five per, and the big 4 there right at the top. So what are the most important factors for implementing care coordination improvement projects in your organization? That's the most important factor. Well, improving patient outcomes, 70%. Number one, people understand that alignment. It's pretty clear. Better patient outcomes, better satisfaction, better financial results, better quality measures. Then number 2, patient experience, increased revenues. Now, I'd be curious if you ran the same survey and you had a majority of CFOs and financial people responding, as opposed to we're overwhelmingly clinical on this response. I would love to be able to ask the same questions of the different audience and see what the differential in results is. I would say that the people getting hammered on Medicare reimbursements, also Medicare heavy institutions and properties, where a larger percentage of revenue is coming from Medicare, and you're getting whittled on the edges by the quality measures, 30 reimbursements, and things like that. And even though everybody talks about penalties, talking about penalties is a big deal, the clinical folks, or people who responded to the survey, 1.4, not the most important. It's there, but it's not the most important. Most important is patient outcomes. This is one of my personal favorites, because when you talk to people about continuum of care, you talk to them about coordinating care, one of the first questions you have to ask them is, what's your definition of the care, of the boundary? How wide do you go? We have some people who say, oh, we coordinate care great, but their definition is we coordinate care within the 4 walls of our acute care hospital, of our office. Once you walk out, forget it. If the physician doesn't belong to a practice at my facility, then they're out there in the ether somewhere. I make no effort to connect to them. So it's very important in here to say, what's your scope? What are you doing? Are you doing, 41% say across my entire care network. This is another follow-up question I'd like to get more on is, what's your definition of your entire care network? How wide does it go? Because you make assumptions, and then you talk to the facility and they say, no, we just do a relationship. We're a SNF. We have these 2 hospitals that we talk to and this doctor's office, and that's our definition of our care network. We know nobody's doing it all yet, and we know that that's very challenging. So this gives us a lot of context. It also, when you move forward with your initiatives going forward, it tells you how big do I have to go? What's my level of scale? And how am I approaching it? So I thought it was interesting. So a quarter of the people said only inside the organization. That's it. If you're outside of the organization, we're not going to coordinate with you. You're out there. You're on your own, basically. I think a more realistic answer was the 21.1% response, which is a small number of defined entities within my care network. This is a Pareto principle approach, which says, here's 20% of entities I do 80% of my work with. So I'm going to start there, focus there. I can make a better impact on majority of my patient outcomes by concentrating my efforts and my time here, as opposed to trying to boil the ocean. And also acknowledging that it's not just inside my organization. And then we had some real honest people, 5.6, who said, I have no idea. I have no idea what the scope of our typical care coordination is. And then another other. Some of the others were interesting. One said they've extended out to do a partnership with an ACO, so they were going to an ACO. Others said, yep, just internal stakeholders and a few exterior partners. And the ACO piece was another one was talking about ACO. So it's very specific. So it's important. It's an important question to ask when you're getting involved in these is, what's our boundaries? What do we consider? Even if it's also one of those things that people assume, but if you get 10 people in the room, there's probably at least 7 different assumptions. So you have to kind of get everybody to state it and get to one common ground. So we know when we're coordinating care, it includes these things. So you have a dedicated budget. I thought this was fascinating. So almost 55% say, no, we don't have a dedicated budget. We make do with existing resources. They say it's the top, 86% say it's the top 5 priority. Okay, but they don't have the dedicated budget to support the initiative. So they rely on existing resources. Okay. About a quarter of the respondents said, we view care coordination by service line, so by cardio, orthopedic, whatever, and only just a little under 13% of a dedicated budget. So to me, and you could have a different opinion, but to me, I look at it, it indicates a reactive approach to improving care coordination and the ad hoc nature of how it's done. Fewer than 40% do have a budget available. To me, you're asking clinical folks to tackle care coordination improvement on a part-time basis, part-time ad hoc basis, and while they're trying to get the patients they have healthy and released, or maintain in the SNF, maintain the health of the patients they currently have. So I thought this was very interesting. And then 6% find the money on an ad hoc basis. That's another follow-up question I'd like to ask is, what does that look like? How do you go ask for it on an ad hoc basis? How formal is it? Do you use a business case? Do you have a bake sale? What's involved here in getting that in a case-by-case basis? I thought that was interesting. So how are you organized? How do you typically manage care coordination efforts? Well, it's a pretty wide variety in the way that people are doing it. We said earlier in the survey that most care coordination efforts use a clinical care view. Well, and over half are managing from within the clinical team or within the service line. I found it interesting that ad hoc and permanent committees are in place for only 17% of the respondents, and 11% are run from the executive team. So clinical management is the overwhelming. Service line is number 2, and we know there's some overlay there, of course. And the other interesting thing here is that I was very surprised at the view that IT management has very little involvement, or very little perceived involvement from the survey folks. And then the home office regional, we see this a lot with the large national IDNs and players where there is somebody at a regional level who is responsible for this, and they might be some form of coordination at the individual facility level. So what are the titles? What titles typically lead? Well, director of case management is the big one. So we know case management plays a big role and a big effort in a care coordination effort, and why? Because they're right in the middle of it. They live at that intersection of patient outcomes, patient financials, for lack of a better term, in terms of what the insurance company will cover and what they won't cover, patient planning, discharge planning, all of that. So they are the most affected by all of these things every day. So that makes perfect sense. It kind of confirms our experience. Again, another big one in other, which means it's spread all over the place. I'll show you some of those titles in a second. Service line directors, that makes sense. That's about the right proportion. That where service line takes the lead. Chief nursing officers, because of the clinical nature. There is a director of coordinated care, 8.5%. We thought we believe that's a positive thing. Specific process owners, okay. Floor directors, we can see that along the lines of service line directors, but a little more geographically or floor-based. Chief medical officer, so then we got some chiefs in there. But overwhelmingly, who's leading it? Well, the clinical folks and the folks that are on the floor doing it. And that has to be because those are the folks with the process knowledge. You can't improve. If you're looking at it as a process improvement project, these are the people that you need that understand the process, that live it day to day. The challenge there is giving them the tools, the techniques, the experience to do a really good job of it and not have to do it on a part-time basis in an ad hoc manner. So it's much more of almost like an organization and tools to do the function better. This is not a surprise, but it is much more of an affirmation, especially even though a lot of decisions have to go up and get presented upstairs in terms of leading the efforts day to day. It's very much in the clinical and the case management realm. Now here are some of the others. So there's the other thing we found is that in some of these institutions, it's not so much about title as it is about personality. There are some people who are much more adept and much more comfortable with treating this like a process improvement effort and understanding what's going on from care coordination, putting the details together, and perhaps the tenacity. We all have a few of those people in every hospital who are the go-to people, and titles almost become secondary. So we find a great variety of titles leading care coordination here. But again, it just backs up that it's, if you want to buy something in a hospital, there's a person there called Director of Purchasing. You go talk to them. It's pretty straightforward. Those titles don't vary much. When you look at care coordination, there's a wide variation in the titles, the types, and the roles that get involved. And that makes sense because care coordination is wide and varied and gets involved in a lot of different places. But in terms of leadership and ownership for that coordination and for making it better is spread. And frankly, that's one of the challenges. But it is what it is, and that's what we're trying to figure out with the survey. Is just ask the basic question: how do you do your efforts? How do you do care coordination? How are you organized to do it? How do you view it? Is it a review? How do you do it? Well, overwhelming process improvement effort. We have a process. We need to make it better. We've got to fix or improve things that we're doing. So 2.8, IT project, training issue, and there'll be a lot of IT guys who would cringe if they saw this as an IT project, because even though tools are involved and IT is a critical support element, they can't fix a bad process. They can support the implementation of things to improve a bad process, change a bad process, help support the change and adoption of a better process. So I thought this was interesting. I frankly didn't anticipate it being this high. Maybe some of you did, but it really framed my thoughts about, okay, everybody kind of sees it pretty much on the same page, at least 3/4 of the folks. So how do you approach it? You have the need. It's process improvement. You're working on a variety of different, could be transitions, could be referrals, as seen on the other slide. How do you do it? Number one is the opportunistic targets of opportunity. Okay, so less than a third approach care coordination efforts with a proactive roadmap based on systematic assessment of current efforts. So most people this number's high. Hey, a 30-day readmission jumped. We got to get on it. Or hospital corrections is we had a few of those last month. We got to stomp that down. There's a new quality measure coming out. We got to start getting our handle on that. So there's opportunistic targets, ad hoc effort. But I was a little surprised at this, that just under a third are saying, look, we're systematically looking at it. We've got, we're figuring out what we're going to do first, second, third. And that could be because, everybody's busy. We know that. It could be the data structure to support dashboards isn't there, or there for a variety of reasons that I thought the roadmap number would be higher, and I was surprised that it's not. So do you have a process? You're ad hoc, you're going after things. Do you have a process to review, approve, prioritize care coordination improvement project? Just a simple question. And close between no defined process and yes, we manage a portfolio of initiatives and review on a regular basis. So this surprised me as well. I thought more people would be purple as opposed to red. And then also so to me it's the folks that we have no defined process. We're just reacting. We're just in pure reaction mode to we have a portfolio of initiatives that we review and they laid them out on the other slide. Here's the types of things we're working on. And then the next step up is we not only do we have a portfolio of initiatives, but we have clinical business cases that are required. What are we going to work on next? Why are we working on this next? What's the impact of working on this as opposed to working on something else? Because they recognize that there's an effort set of resources that are required in order to make process improvement happen, and also that these folks are busy. Everybody's busy. You got to do other things. You got to be in the process. You got to be into the process, be intimate with the process in order to change it, make it better. And that means you're busy because you're taking care of patients, especially when your stated goal is 80% of the time is patient outcome or patient experience. So I thought this was interesting. Do you even measure the impact of care coordination improvement efforts? I thought this was interesting. Right? If you're into process improvement, and one of the tenets of process improvement is you can't improve what you can't measure, then do you measure? So I asked them. And most people came back and said, we measure what we have to measure. We measure the CMS stuff. So basically, we're letting them tell us what we need to measure because I'm responding and reacting because I've got to get my 30-day readmissions down because I've got a lot of Medicare patients and I'm going to get dinged financially, and I understand I've got to do better patient outcomes to get my 30-day readmissions down. Okay, that's typical. So I thought that was interesting. And then the right behind that is we've got a dashboard. Now a lot of the things in the dashboard, I'm sure come from the CMS measures, but there may be some other things. I saw a great presentation yesterday where they were using critical indexes like how quickly can you get an appointment, right? So get one same day, or how what's my utilization? It was a medical school and a university medical setting. So how often are my physicians available on a monthly basis? What's their opening? How often are they in clinic? How many hours are taken up? So they're doing utilization reports, things that aren't necessarily driven by CMS, but help them run their business better or help them provide better care. It was pretty interesting. So some people are doing, we establish CMS measures. Some people are going beyond that and saying, in addition to that, here's the things we need to run our business better and run our outcomes better, and we're tracking those in addition to CMS. And then, frankly, I was very surprised at 20% saying that we don't accurately measure. We're doing a bunch of stuff, but we don't really measure it, or we don't measure it accurately. We just kind of do a rule of thumb. And then some of the other responses, because that was not 1 or 2%, and this is good honesty. We measure, but we're unsure of the process. We measure, but we're not really sure what we're measuring or whether it's really good. And we have individual measures, but they're service line based. So we let the service lines do their own thing. And I love this one. We're getting off the ground last 6 to 9 months, so we're not looking at results yet. So we're just getting going. We're not measuring initial stuff yet. We'll let you know. So I thought that was interesting. Best practices. We asked them, do you feel that what you're doing, going after things, budget, no budget, different titles, measure, not measure, whatever you're doing, do you feel that there's some best practices emerging from your improvement efforts? And most people said yes, that was good. That we track it and we document it, we understand it. 31%, not only do we track and understand, but we incorporate it into future efforts. So lessons learned, how do we approach and propagate those best practices and institutionalize them going forward. And I thought 21%, scary but honest. We don't track. We just got to do it. And there was one actually interesting. There's one, just one that we know of, skilled nursing facility. And so we used the QAPI process, QAPI process from CMS, and it appears to be using positive results. So that's out there. The tool's out there to use it, but we had one person say, we're using it. We're getting good results from it. So in some of the others, they're still learning about it, still coming up to speed. We're still too new at it, so check back with us later. So 40%, 70% say, yeah, we're getting some things are emerging, and some are saying we document it, some are saying not only do we document it, we put it into future efforts. So that's interesting. And then finally, do you coordinate and attempt to build on your care coordination efforts? And that was really kind of built on the last question. Is it more of a series of ad hoc firefighting, get this number down, get that number down, oh, geez, that number went up, we got to go after that number? Or is there a bigger picture here and a bigger coordinated effort that says, no, we're after these numbers, but we're going to do it in a coordinated way, and we're going to build on it, to build our experience and work on the process and get it better. So we thought that we'd ask this question. So thought it was interesting. 52% actively look for actions to further refine our results. Okay, that's good. That's very good. But 28% do much more. Lessons learned. What do we learn? What do we do better? And 8.5% said, yeah, we get by an ad hoc basis, and 9.9 institutional memory. So if somebody doesn't remember it, it doesn't get brought up. So you can see the layers of engagement here, I guess, for lack of a better term, saying, yeah, we're really on it. Yeah, we're not on it at all. We're kind of on it. If we remember it, we'll bring it up. So what are the implications? This is my read on it, our read on it. So I'd be interested in, I believe you're going to be able to download the report right from the presentation here. If not, you can go onto our site at thinkdcs.com, download the survey. I'm really interested, because it's the first time we're sharing with other people. What's your thought, your read? What did I miss that you guys see that I didn't? Because I'm sure there's plenty there. But this is the feel that I got after I went through it. I said, look, this is mostly clinical, and it falls mostly on the clinical people. So they're challenged with the here and now. I've got X number of patients. I've got X number of patients in bed. X number of patients. I've got to get up. I've got to get out. I've got the pressure. I've got X. I've got all kinds of things going on. That's my main job. I got to make people better. I got to get them out. I got to get the best outcome I can do with what I have to work with. But I'm also have to respond to all these regulatory pressures, right? Third-day readmissions, meaningful use, HVP, and it's, maybe people can tell you that meaningful use is going away, but it's not really going away. It's all transferring, becoming MACRA and MIPS, and any indication I see that none of that's going to change anytime soon. It's just going to morph. It's just going to be other things happening in other ways. And the thing I can tell you for sure, as you all know, is more and more of that is getting tied to financial incentives. So before, what would have been, I have a bad number, now it means not only do I have a bad number, but it's costing me money. And that, you might not, that's costing me money, that especially in a nonprofit situation, that then takes away from money that I can invest in other things, because the margin in the cash flow gets thinner. So it could mean a difference between that new X-ray machine or not, things like that. Capital that goes back into the business to help improve patient outcomes. So, and it seems like the clinical staff has got the burden for the effort. We go in, we sit in plenty of meetings, and it's clinical staff. They're the guys coming in once a week, meeting on it, once a month, meeting on it, coming in. They're all rushing in. All the pages are going off. It's a hard thing to focus on. So they're charged with finding solutions and improving care coordination, but what kind of additional tools do they have? What kind of training? We saw in 55% of the time they don't really have a dedicated budget. They're going to scrounge around for it. So it's a tough spot. It's a tough spot to be in, and it's especially to make a meaningful difference over a sustained period of time. And some just feel it's hard to get ahead. How do we get? I'm just shoveling, going up against the tide. I've got population health. I've got some people deal with ACOs. They've got bundled payments coming. They've got MACRA and MIPS coming. I'm just trying to do the best I can. Let's get the best patient outcomes we can with what we have, and it keeps changing, and it can be a defeating feeling for some folks. But for most people we talk to, it doesn't mean they give up by any stretch of the imagination. It's okay. It's time to dig deeper. but it is a recognition that it's a hard position to be in. So we asked ourselves, based on what we see, our best practices emerging, what did we see? Well, it's a couple of good things, 4 good things, right? 40% do have a dedicated budget for care coordination, so that's good. 30% do work from a roadmap based on a systematic assessment, so they do have their act together in terms of understanding what they're going to work on. 15% require business cases, clinical business cases, so they've got that extra layer of rigor and discipline. And just under a third have established dashboards to track and document improvements and incorporate into further efforts. So they are using dashboards, they are being updated, maybe not on a daily basis, not that they have to be done on a daily basis, but certainly on a monthly or quarterly basis. And they're using that to make decisions. So we saw that was good. However, we only found one respondent that does all of it, all of the above. I looked at that and I said, that's good, but how many doing all of it? Just one. So there's a lot of room to get better is the net. So we think it's clinical knowledge combined with process improvement. We think that is that's at the core of making this stick. We found a lot of people, clinical knowledge is there, varying levels of process improvement. It could be with one person and they naturally take the lead because they're the process improvement people. But we've also found, especially in process improvement projects, that small changes can yield big results. And it doesn't have to be exceedingly rigorous. It's a number of small things that can be done better depending upon organization that yield big results. And those are the things you really look for when you start working with these groups, because everybody's got patience, everybody's got to make things better. And how do I get at it? And the other is a recognition that process improvement's a skill. It's not just a thing. It's a skill that people need to work at. And it's a skill that is a number of tools, techniques, and education. That doesn't mean that everybody has to be a certified Six Sigma black belt or whatever your process methodology is. Doesn't hurt, but that doesn't mean that you've got to do it all from the top down. This is what happened when this stuff first came out. They said the first thing you need to do is train everybody in your organization on this rigorous process. And then they realized that nobody's going to do that. So the result is how do you bring along the skills when required and maybe a little ahead of time, and then how do you begin to see results, make small changes, see better results, broadcast those results, promote that success, go to the next process improvement, go to the next clinical improvement opportunity. And it takes time. I saw a presentation yesterday, different presentation from the one I mentioned earlier, where they were doing data marts and things like that. And it was an overnight success, 10 years in the making. So there was a persistence and a institutional buildup of their skills and their knowledge, which resulted in first small wins, and then those compounded. Then it was a lot of different small wins, and then the small wins got together to yield some big wins. But it was a sustained effort over time, and not just a, hey, let's get together and fix this one problem, and then we can walk away from it. So those are the ones who yielded the best results over time. Okay, so what can you do? This is and you can get a copy of this if you want it. This is what can I do as a tune-up or checklist based on what we heard from the survey. These are questions that you could ask yourself and ask about your care coordination improvement efforts. So it's a series of just five different things. How do you make decisions? How's your team, how's your committee structured? Do you have executive level support? Everybody says that's important, and the reason everybody says that's important is because it is important. Are you going to do all this work, take it upstairs, and be ignored? It has to be important upstairs. Otherwise, you're facing a real uphill swim. Okay. Do you have the training, education, process improvement methodologies, and tools? This isn't necessarily top-down rigorous, but there is a number of ways you can provide the tools, techniques to get everybody on the same page without forcing everybody to go back to school for a year. And you need to be able to complementing that with clinical skills yields huge dividends. So what's your committee look like? Is it aligned to the organization? Is there a stated committee mission or charter? What are you guys all about? That helps when you get into prioritization issues. Do you follow any industry-proven methodology or approach? Doesn't mean you have to. There's a bunch of different ones that you can choose from, but you should look at some and pick one or two and try them. It's okay to pilot a few different ones to see which one fits your organization the best. It gets back to what's your definition of care network. Again, it helps get the committee on the same page. What's our definition of the care network? Where's the boundaries? How many people? That is an important question to answer and get on top of. Is it too narrow? Is it too broad? And does it align with the patient's definition of their care network? We all have our own care network. So I'll have an individualized care network. But if 80% of my patients go to one ACO and I'm doing care coordination stuff with two other ACOs, you have nothing to do with the third one, is that really aligning to my patient's needs? Simple question, but something people don't always think about. How are you doing your project management and your roadmaps? What does that look like? How does something get on your roadmap? How does it get approved? Right? How are they prioritized? It's basic housekeeping and how you run your team, but it really helps you to be more efficient, and being more efficient in this situation helps you be more effective. And measurement, right? What are you measuring? Why are you measuring it? Who owns the measurements? Some of the follow-up was very, very good. Some of the folks were telling me who owns the different measurements, and some were very clean and clear that this one owns this one owns this one, and some weren't. So what are you measuring? Who owns it? How often are they updated? How often are they reviewed, especially upstairs? And how does each measure translate into quantifiable results? And what are the nature of those results? Some of those patient outcomes, you have patient outcome results, but are there also financial results that you can tie to the improved patient outcome results? None of these questions in and of themselves is terribly difficult, but taken as a whole, you're going to be able to do really tune up your existing efforts. And finally, on this checklist is promoting success. We find that the way that a lot of people get stuff up through the organization is you get a small win and you broadcast it, you tell everybody about it, and then you go for another one, you can't rebuild the whole house at once. So how do you promote success and get the naysayers or the people on the edge to go, you know what, this is pretty good. This is helping. And you'd be surprised how many people do great stuff. Nobody knows about it. And as a result, people go, what are you doing? He said, well, we're doing great stuff. I didn't know that. So very, very important. What's the common language of results? Are you an ROI shop? Are you measures? What's the combination? What's going to work for your audience that they will say, yeah, that was successful. And then how are you tracking your investment? Because whether you're directly budgeting or indirectly budgeting or ad hoc budgeting or no budgeting, but no budgeting means you're taking out of opportunity costs from a whole bunch of other places. What's your return for investment? Because eventually someone's going to ask, why are we doing this? And you need to be able to answer for these 5 reasons. So that's what I have. That's what we got out of the survey. That's our interpretation of some of the pieces of the survey. I'd be interested in your feedback on the survey once you've had a chance to go through it. And I thought overall I found it was very interesting. It was a worthwhile effort, and we have a much cleaner or quantifiable understanding of what people are doing and why they're doing it. So with that, please download the survey results. They're on you can download it right from the presentation here. You can we'll send you the presentation as well as a follow-up. Also out at www.thinkdcs.com. Like I said, I'm very interested in your read on these results and against your experience. So please reach out. My contact information is there. Call me. Questions, comments, insights that I missed, or various interpretations. There's a sounding board. That's part of the dialogue. Mostly this is about talking, comparing notes about what other people are doing so that you can impact your local efforts.